Welcome to Health Systems CIO's interview with Dr. Barry Stein, Chief Clinical Innovation Officer and Chief Medical Informatics Officer. Dr. Stein is also a practicing vascular and interventional radiologist with Hartford HealthCare. Dr. Stein, thanks so much for joining me.
Thank you, Anthony. Pleasure to be here.
All right, very good. So we're going to talk today about enterprise imaging, but first, if you want to tell me a little bit about your organization and your role.
Hartford HealthCare is the largest integrated healthcare delivery system in Connecticut. Over 40,000 employees, 500 locations, and it's a fully integrated healthcare system, taking care of patients from birth until the end
Hmm.
across multiple specialties, in fact, all specialties, in a very comprehensive way. Our focus is improving access to healthcare, affordability of healthcare, improving equity, and excellence, meaning quality and safety. Those are our four strategic pillars. And the vision at Hartford HealthCare is to be the most trusted for personalized, coordinated care.
Excellent. All right, very good. As I mentioned, we're going to talk about enterprise imaging, which is a term that I think it might be interesting to hear you kind of define what it means to you, um, and what the shift means from a sort of a traditional imaging approach, if you want to give us a definition of that, and where people are trying to go now under this idea of enterprise imaging. What does it mean, and why are we trying to get there? And then what are some of the things that we do that further that goal, that move us in that direction?
The enterprise imaging has been a concept that has been around probably for more than a decade. And it really started when PACS started on the scene, and very quickly, many healthcare systems had organically developed a hodgepodge of different PACS systems, different ways for clinicians to see images. And as healthcare systems grew, it became more and more difficult to seamlessly provide access to the entire imaging history of a patient for the clinician. In other words, if a patient went to one hospital with one PAC system within the same system, but needed to go to another hospital or another facility in the same healthcare system, because of the different systems not connected on one particular platform, it became extraordinarily difficult for clinicians to have the full picture of the imaging history. When the electronic health record came about, most of the electronic health record companies did not have an imaging platform. They certainly had a platform to collect structured data and non-structured narrative data, but not imaging. So it was a real significant element that was left out of the strategy of an electronic health record. So at Hartford HealthCare, we have now 7 acute care facilities and over 500 ambulatory facilities and over 30 odd imaging centers. And you can imagine how difficult it would be if we didn't have one enterprise imaging platform such that the clinician ordering the study and taking care of the patient would have a full view of the patient's entire imaging history from every facility instantly, including the reports. Our patients would have their entire imaging history in the palm of their hands, and the radiologist reading the study, even if they're in different groups, would have access to the history of the patient's prior studies to compare to from any facility within our enterprise. So that really was the the goal and the reason why we developed our enterprise imaging platform was to consolidate all imaging on one platform to achieve the goals through three different lenses. The first of which was the patient. We didn't want the patient to have to carry CDs or worry about where the imaging might have been and to get the images to the next facility. We wanted our patients to have access to their imaging history and reports 24/7 the moment the imaging was acquired and the report was signed out. For the referring clinician, we didn't want them to have to search and wonder where imaging was performed in our large integrated healthcare delivery system. We wanted them to have access to the entire imaging set within Epic, which is our electronic health record. So when they looked at their particular patient and they wanted to see imaging, they clicked on the image in a unified viewer within Epic, and they see the entire history, including reports from every facility. That's the second lens. The first was patient. The second is referring physician. And the third lens is for our radiologist, the interpreting specialist, to have access to the prior studies from all parts of our organization to render high quality reports.
All right, very good. So is one way to think of this moving in stages? I interviewed another individual in a position similar to yours, and what he said was sort of a first step is perhaps getting every particular specialty down to one system, like one PAC system. So you could theoretically, I guess, have in cardiology or radiology a number of different PAC systems within that specialty, like you mentioned at different hospitals. So he said it's almost in stages. One is let's standardize on one system per ology, and then let's go crossology with maybe a VNA and have all those feeding into a VNA. So it almost was like a couple of stages of standardization. Does that make sense, or what are your thoughts about that's sort of a general? We want to give people. It sounds like you've achieved some really significant milestones here, and I'm trying to give people a paradigm in their head of here are some high level ways to move in this direction.
Yeah, I think we did it almost the other way around. We created a vision, and the vision that I just explained to you, that it's necessary to think about this through three stakeholder lenses: the patient, the referring physician, and the radiologist. And for us to accomplish that, the ultimate goal would be to have images in a central archive, which is our vendor neutral archive, that is integrated with our Epic healthcare system, and start there. So that was the vision that folks understood and really wanted. The second piece was, okay, we can't do it all at once. Let's break it down into different I would say sectors. The first of which is we started with radiology. The next was cardiology. The next was point of care ultrasound and imaging. The fourth one was visible light, taking pictures with your camera and your iPhone. And in the moment, we're in the process of doing pathology, ultimately with the same goal, that if you click on a patient's name in the EHR, it loads the unified viewer, and you can see radiology, cardiology, visible light images, point of care ultrasound, digital pathology, etc. So when it comes to deciding should we have a unified PACS for each ology, we realize that if you in an organization that may have different groups that are very much devoted and comfortable with their PAC systems, that's a resistant point and a point that could slow the whole process down. So with modern day technology, it's very feasible to have multiple PAC systems because we want to make sure each stakeholder is comfortable doing what they are comfortable with and getting what they want. If you've got 5 radiology groups or 3 radiology groups and each has a different PAC system and they comfortable and good and efficient within this system, that should be okay. What we requested and everybody agreed was for the images in their facilities to go to the VNA so that the patient could have access to the images, no matter what PAC system is irrelevant to the radiologist or the clinician. So we developed our architecture such that we could accommodate different PAC systems. Now, I'm not going to sort of say to you that having different PAC systems is frictionless. It requires a little bit more effort and technology to make sure that the interoperability is smooth. And there are ways to do that that are elegant and certainly achievable. So in our radiology system, right now we're down, I think we started with 5 different PAC systems, most consolidated into one, but there's a large group that's on another. And, you know, we continually work out the small kinks, but ultimately they work off their own PAC system. The radiologists are happy. They're seeing all the images from the rest of the enterprise. The referring clinician is seeing all the images in the VNA in Epic, and the patient can open up their MyChart and see the reports and images, and they don't have to worry about different systems. So we chose that route. When it came to cardiology, we want to have one main system, but there are 1 or 2 other systems, and we can accommodate. Point of care ultrasound, the same thing. Digital pathology, we have 2 pathology groups. We may need 2 different systems. And when it comes to visible light images, as you may imagine, people are using different devices to take pictures. So we felt that that would be a major barrier to progress. And I believe that was one of the key decision points that allowed us to accelerate as quickly as we did, remove as many barriers through each respective stakeholder lens to get to the ultimate goal of one VNA, absorbing all the images from across the enterprise that allowed our patients to get images, our referring physicians to see it in Epic, and our radiologists to work in an environment that they're comfortable, or cardiologists, or pathologists.
It sounds to me like this is a fundamental decision point that organizations have to make around strategy. It's really fascinating to talk about this to me. Um, what you have described is extremely interesting because from what I'm hearing, your goal was to let people use the systems, the PAC system specifically here, that they are comfortable with. You will have less pushback. It is always extremely difficult to get people to stop using a tool they are comfortable with. And we talk about this in all kinds of applications. The concept is called, I'm sure you know, application rationalization, going from many to fewer. It's extremely difficult from everybody because you are taking away someone's favorite toy or tool. So it's hard to do. But even though you said that you want everyone to use what they're comfortable with, you have described a bit of consolidation, right? So you mentioned going from 5 to 1. So it almost sounds like a hybrid strategy where, yes, we want people to be comfortable with what they have, but where possible, we want to consolidate. And where impossible, we may have to live with interoperability. Tell me your thoughts.
Yeah, so you hit the nail on the head. I would say the application rationalization is a huge driver in our organization for all the reasons that your audience is fully familiar with. If the goal to achieve enterprise imaging through the stakeholder lenses that I just mentioned is the primary goal, there's always compromise in a large, multidisciplinary organization.
Mm-hmm.
And for us to move forward, we have to compromise. So I would say the majority was around application rationalization, but we had a large radiology group, and we still do, that was very much wedded to their PAC system for other reasons. And we worked on the interoperability, and I think that for organizations that want to move ahead quickly, pick your battles very, very, very carefully, because that one could really stop it in the water, dead in the water. And then who loses out? The patient, the referring physician. And at least at Hartford HealthCare, as I mentioned, the vision is to be trusted for the most personalized, coordinated care. That's our North Star. Are we going to allow the friction between you should be on one PACS and convincing somebody else to the detriment of achieving that vision? It would be a hard argument to make.
So the decision points here, it's again totally fascinating, different than the EMR. The reason Epic is where it is because we don't do this on the EMR side. The industry has decided we will not have multiple EMRs in a health system. We will have one because um, interoperability, I guess, is not all it could be. Also, I think part of the reason is that data transfer from one EMR to another is not as difficult and onerous as moving images from a well-used and old PACS system into another one. The files are massive. I think it's a different proposition. I think the data transition is easier with EMR data than it is with PACS data. And that's one reason we may be okay living with more than one PACS is because the archiving and data transition is so onerous. Does that make sense?
Yeah, there's a huge difference between comparing consolidated EMR and having multiple EMRs versus having multiple PAC systems. If you think about the stakeholders in the audience that use the EMR, it's every clinician in the organization. And if you, as a clinician, a referring physician, are working in multiple facilities, ambulatory and acute, in an environment, you want one system to go into to find all your information.
Mm-hmm.
All right? It's key. It's not only important from a clinical standpoint, but from a revenue cycle standpoint, from a compliance standpoint, from a quality data standpoint, everything. When we're talking about PACS, we're talking about a tiny segment of the clinical population of a large healthcare system, meaning the stakeholders are a small percentage of the larger group of clinicians. And most radiology groups, if they're going to be moving different hospitals, they want to be in an environment that they're comfortable with.
Mm-hmm.
It's not going to impact the clinician, and it's not going to impact the patient. In fact, it's going to help them. So I don't believe the comparison is an equivalent comparison at all. It's, to me, night and day. The two function differently. The stakeholder, there are the amount of stakeholders that have to be entertained with a consolidated EMR versus the few on the PACS is what I don't even know the ratio, but very significant.
And that's why the strategies are different.
Yeah, the strategies are markedly different. And if we use So at Hartford HealthCare, we have Epic throughout
Mm-hmm.
for all the reasons that I just mentioned and a whole lot more that everybody else knows. And we're very grateful that we're on one EMR because it allows our clinicians to see everything in one system.
Can you talk a little bit I'm sorry. I'm sorry. Can you talk a little bit about the integration with Epic? Is it individual PAC systems feeding into Epic, or do the PAC systems feed into the VNA that then feeds into Epic? And what does it take to have a good solid integration there? All roads are supposed to lead to the EMR, like you said. So what does it take to have a good integration with your imaging systems and Epic?
So, it took a little bit of work up front, but now it's a well-oiled machine. Basically, the fundamental premise is we have a Sectra VNA, a Sectra Enterprise Imaging Platform that's
Hmm.
uh, uh, the Sectra platform. And we worked very hard with Sectra and Epic to integrate Sectra's unified viewer into Epic. Easy launch, and it allows access to any image
Hmm.
on the Sectra platform. So if the images from any packs are pushed to the platform and they're on the platform, you should then be able to see them through the unified viewer in Epic, because Sectra and Epic are tightly integrated with the VNA and Epic. So any image that's on the Enterprise Imaging Archive is visible in the viewer. Simple as that. Now, obviously, there's some technicalities, but that's not a major barrier at all. It's not basically saying, okay, you use X PAC system, therefore that system has to then work with Epic to integrate a viewer. No, no, no. The first and only step is for us to get images, current and past, onto our VNA.
Hmm.
Once they're there, we can access them through our unified viewer that's integrated with Epic, no matter what system the specialist is reading from. It's irrelevant.
What's what's next for you around this area? What are some future goals, things, further integrations, or your vision of imaging, how you want imaging to work at Hartford HealthCare 3 years from now?
And again, I'll go back to keeping in mind trusted for personalized coordinated care. Personalized is a word I'll come to in a moment, and how we're going to continue to do that. And coordinated, meaning the patient needs to be able to see their images whenever they are, wherever they are in the world, whenever they want to, easily. Number two, our referring physician should have access to anything they order anytime. And our radiologists and our interpreting specialists, cardiologists, pathologists, need to have access to the latest and greatest technology moving forward. With that being said, we've done radiology, we've done cardiology, we've done point of care ultrasound, we've done visible light, we're doing pathology. So what's in the future? We've got to continue to work on pathology, which is not totally mature. It's almost 10, 15 years behind radiology. And also understanding that and then we would like to consider all the video, intraoperative video, etc., also being stored in the same environment so that everything's accessible in their unified viewer. So that's the coordinated care. The specialist, the referring physician, and the patient are all tightly coupled here. They're all
Hmm.
getting what they want and need 24/7, contemporaneously, coordinated, tightly coordinated. So how do we make this more personal? Artificial intelligence is going to allow us to personalize care much more accurately and much more granularly. So where does radiology fit into the picture? Excuse the pun. Radiology has always been at the tip of the spear in terms of artificial intelligence and the diagnostic capabilities to improve that, as well as the quality and safety of the care that we provide. At the tip of the spear, far ahead of almost any other specialty. With that being said, we haven't unlocked the full potential of artificial intelligence to personalize more care that's embedded in every single image that we acquire. For us to unlock that full potential, we need to have our images in one platform, organized such and architecturally designed that when we're developing algorithms, it goes beyond just being able to diagnose an intracranial hemorrhage, a pulmonary embolus, an aortic dissection. It goes far beyond that. And at Hartford HealthCare, we have a center for artificial intelligence in healthcare with the vision and goal of unlocking the full potential of AI for our patients in a safe and trustworthy way. And we've built capability to do that over the last 8 years. That includes understanding that you can't do this alone. So we have world-class ecosystem partners to help us develop algorithms to predict and prescribe and optimize patient care. The likes of MIT, Oxford University, Google, etc. Number two, we've done an enormous amount of research around this domain, including most recently, and which is pertinent to your question, using multimodal data to increase the predictive capability of these algorithms for a disease process. It goes beyond just using radiology. You need radiology. You need EKGs. You need structured data. You need unstructured data. So if you think about it, we're using multimodal data now to improve the personalization of the care we give. And radiology is such a fundamental part of that. And as we think about enterprise imaging, we have to think about how that connects with the multimodal data strategy that an organization has to allow algorithm development, deployment, validation, etc. The third component to our center is governance around when do we allow AI into our organization. The fourth piece is how we integrate this in a very disciplined way in our enterprise, such that our clinicians who are using these algorithms understand what goes into developing them, what it is, what it isn't, how to recognize a problem when it occurs, how it may change, and how do you monitor it. There's also an enormous amount of education. And then the last pillar is what we call our data layer. We have a partnership with Google Cloud Platform to develop that data layer that allows the multimodal data organized in a way that we can unlock the potential of AI for our patients in a safe and trustworthy way. So we've built our enterprise imaging platform. We've built our Epic environment. Neither one has the capability to harmonize all that multimodal data with the capability to develop algorithms, run algorithms, monitor algorithms, and we need to figure out an efficient way to connect and transfer information to these multimodal data platforms from the EHR, from the imaging enterprise platform. And that hasn't been completely worked out, which is that future. And that future is all about unlocking the power of AI in a safe and trustworthy way to provide personalized, accurate care for our patients.
Excellent. I want to get one more question in, Dr. Stein, and then I'm going to let you go. My guess is that I'm wondering where the push for this comes from. If it comes from the clinicians and the users in the ologies. Um, so you've got sort of the practitioners and the clinicians. You may have informatics folks embedded in those specialties, depending on how the organization is set up. You may or may not, depending on if IT is embedding informatics folks in those disciplines, and I'm not sure who they report up to. Then you've got folks like yourself that sort of bridge that gap between the IT world and the clinical world, such as in your position, the two titles you hold, and the CMIO title, which is a very common one. And then you've got people like Joel Venko, your CIO, who is one of our traditional readers, great friend of our publication. So you have Joel, a CIO who's living firmly in IT, folks like yourself that are bridging IT and clinicians, and then you have the clinicians. When it comes to enterprise imaging, is there a typical way this push gets started? And then what are the keys for both the CIO role and the CMIO role to move this forward? Because it seems it could go any number of ways.
Yeah, so great question. And I think historically, because Epic was such an expensive rollout for not only our organization, but every organization, boards have to approve hefty checks, and Epic has a very prescriptive way of deploying Epic. It's almost like a tactical kind of thing. IT did a lot of that over the last decade in most healthcare systems, pushing technology to the clinicians. We all know there's a huge revolt in the country around technology burden that hasn't made their lives a whole lot easier a lot of the time. I think everybody most people would agree that at least we've got the data and everything in the one place so that it improves quality and safety, but it has increased the physician or clinician burnout very significantly.
Mhm.
So when I personally took over, I think 6 years ago, informatics falls under the clinical affairs department, reports into IJ Kumar, Chief Clinical Officer, and we represent and support and advocate appropriately for our clinical partners. And our organization flipped the operating model on its head the following way. We made a compact with our institute leaders. We've got 7 institutes: heart and vascular, cancer, neuroscience, behavioral health, bone and joint, kidney, okay? We've got 17 clinical councils that standardize clinical care across the enterprise and 4 different regions. And we basically said the following. Clinicians are now going to surface the problems they want solved. They're going to work with informatics members that are under clinical affairs and are embedded in each institute, each council in each region. You're going to work together to crystallize your problem statement. What problem are you trying to solve? And then once we've done that, we prioritize. What's the most important problem? You can't have 50 things or 60. You've got to have a few. And then we work with IT partners like Joel's team to find the best solutions. And in partnership with the clinician champion that's surfaced or the institute, we work in an iterative way to make sure that the solution solves the problem. So fundamentally, this isn't put in a ticket in the loudest voice. You've got to have a crisp problem statement that is a priority in the organization, that is a consensus signed off by leadership, worked together with informatics, and then we go to IT, who are the experts in the technology, to help us find the best technology. And that has worked magnificently to get clarity as to what are the priorities. And it's not 3 or 4 different ways in. The only way you can get your problem solved by technology in our organization from a clinical standpoint is the way I've just described. So we've empowered the clinician with caveats. They've got to work on their problem statement. I'm not interested in this solution. And they've got to prioritize it. If you can't do that, then expect somebody else to do it for you.
That's fantastic, Dr. Stein. That's absolutely wonderful. Great advice for our listeners. Wonderful interview today. I want to thank you so much for your time.
You're very welcome. It was my pleasure.